I'm so proud to really be in contact with this institute, one of the best institute in my opinion in the Middle East. It was inaugurated on the 29th of May 2010. His Highness, the ruler of Sharjah and the president of the university, Dr. Sultan Al-Qasimi, Allah Hafza, he actually inaugurated the center on the 29th. And since then, the working team, has worked really, really hard in order to establish a center of excellence in not only surgical training, and multiple other areas of training. This is why the name is actually Sharjah Clinical and Surgical Training Center. Since its inception in 2010, we have actually run over 23,000 participants. Sorry, 23,000 participants had attended our courses. Our courses around 1,700 courses. Over 45% of our courses is actually surgical. And Prof. Raj will know, and I hope at least most of the attendee are surgeons. So you know what I mean by surgical training. Surgical training is not the same. And surgeons goes through different level of training. But the very basic level of training are basic surgical skills. And Prof. Raj knows very well that the Royal College of Surgeons of England have a very prescribed course, really, and it is their course. And they chose our center to do these courses. And we have done, I think, around 28 courses with the Royal College. We do it with our staff, but it's endorsed by the Royal College of Surgeons of England. Now, in addition to the basic is basic, and really it's about nodding, about very basic things. But even the most advanced surgeon of the senior surgeons also will need, go back to the beginning, please, I'll go, Muhammad. Even the most advanced surgeons, Prof. Raj will agree with me, at times need some sort of training for the new technologies. For example, the new technologies, even we're talking about hernia. How many types of hernia, how many types of mesh we have actually is in the market? So every time we have one, the surgeon need to be trained on it. Next, please, next. So in other words, everybody needs a training, whether they are junior surgeons, maybe planning to do the MRCS, or they are doing the fellowship, or of course the most senior surgeons also. The Dr. Professor Qutaiba is the chairman of the board of management and the dean and vice chancellor of the medical campus. Next, please. Next, please, Hamad. Okay, as I said, over 25,000 of participants have attended around over 1,600 courses. More than 600 of them are surgical courses. And of these, also we have American Heart Association. We are a recognized center of American Heart Association. We have lots of laser courses as well. And we have actually graduated 11 batches of professional diploma in OBG. Luckily, last year we have been accredited to run the postgraduate diploma in OBG ultrasound, and we are very proud of that. And the plan is to accept the new batch very soon. Next, please, Muhammad. Next, please, Muhammad. Okay, this is our progress over the year, and as you can see, it's the yellow is the red is the participant, and the blue is the courses. And as you can see, over the years, we have run really beautifully well. Next, please. Okay, as I said, in addition to the surgical courses, we run American Heart Association clinical courses. We run laser, lots of laser courses. We run also ultrasound, as I said, in addition to some other non-specific courses we run at our center. We are a training center and we train people in anything. Next, please, Muhammad, لو سمحت, please. Muhammad. Ahmed, next. Okay. Okay, these are the levels of surgical training: basic surgical, basic laparoscopic. And today's topic, of course, Prof. Raj will talk about laparoscopic surgery. He's very experienced, and I will not say anything here. But also, we have different level within the surgical training. As I said, very basic, then virtual reality, then animal organ, then live animal, then fresh cadaver brought from the state. And of course, we do real patients as part of the training when it's possible. When it's possible. Next, please, Muhammad. Okay, these are our major participants. Look at kindly, if you are not talking, can you please mute your mic? Kindly, please mute my mic so everybody listen. And okay, so our major partner, of course, the Royal College of Surgeons of England. As you can see, we are examination center of the center of the Royal College. We are also partners with the Ministry of Health, UAE industries. We have Johnson & Johnson stores, Olympus. We have all sorts of Carl Martin, and we're robotic recently with Cambridge Robotic. And in the next few weeks, when after this isolation hopefully released, we will be bringing our Da Vinci training, inshallah. Next, please. Next, Muhammad. So that I will not take more than 15 minutes, I promise. These are some of the areas within the center. This is for basic surgical. Next, please, Muhammad. Thank you. And this is our wet lab. This is our operating theaters. This is live animals training, but we can use also laparoscopic, where we can use organs rather than live animals. Then this is orthopedic courses in another operating theater. As I said, we bring cadavers from the state, and we do knee replacement, hip replacement, shoulder. We do spine. We do ENT, and all sorts of courses. We do own fresh frozen cadavers. Next, please, Muhammad. Next, please. These are basic life support in general, life support. We have BLS, ACLS, advanced pediatrics, and so forth. Next, please, Muhammad. Look, in addition, we paid attention to every single details. So people who attend our courses enjoy it, hopefully, and enjoy the training. And then they need an area to relax. And this is an area, even look, the color we have. I mean, really, we worked not me, the whole team worked very, very hard to develop something, center of excellence in the training. Next, please, Muhammad. Next. And as I said, we run a professional diploma, I think 9 batches or something like that or more. And we've just been accredited for postgraduate diploma in OBG ultrasound. Next, Muhammad, please. And this is robotic surgery. We have already brought Cambridge Robotics. They have done so many courses with us during the last year or so. And we are starting, hopefully, after this COVID-19 isolation, we will start, inshallah, with Da Vinci robotic bringing it. Now, with this, I think I come to the end of my talk, and actually, it gives me a real pleasure to introduce to you my colleague, my friend, Professor Rajkumar. Professor Rajkumar is a very, very well-known laparoscopic surgeon. He has over 30 years of experience in laparoscopic surgery. He's a graduate from Madras with MBBS and MS. Then he is a fellow of all of the surgical Royal Colleges, England, Glasgow, Edinburgh, Ireland, and so forth. And with this 30 years, also he have lots of experience in liver transplant. He was participating in the first liver transplant in 1995. And I hope he will share with you some of his experience. We are hoping to bring him to our center. We will be delighted to have him in the center. And the beauty about Prof. Rajkumar also, he doesn't only offer these laparoscopic courses on animal or organs, something like that, but he offers it on live surgeries in his institutes, in multiple hospitals in this, and this give us the edge on that. With that, the floor is yours, sir.
Thank you, Professor. To everybody who's watching, I want to start by thanking Professor Nabil Sulaiman. For those of you who don't know, he's just flown over to Australia. It's probably 11 or 11:15 at night in Australia, and from Melbourne, Professor Sulaiman is addressing us from a hotel room because he's been quarantined. So a big thank you to him. As you all know, those of you who understand the Sharjah Clinical and Surgical Institute is one of the centers of excellence. I have gone there and taught several times, and I have actually gone there to learn as well. I got my robotic training with Cambridge Medical Robotics at the Institute, and I look forward to a long and fruitful relationship with them. With these words of introduction, I would like to thank everybody for coming and to say that over the next 20 to 30 minutes, I'm going to try to bring about some important guidelines and frameworks as to how we should consider COVID as practicing laparoscopic gynecologists or laparoscopic general surgeons. Mohammed, could I have my first slide, please? Probably in India, it used to be Amitabh Bachchan, or it used to be Trump in US, but now the one word that is on everybody's lips and ears is COVID. Just COVID all over, like the 1918 Spanish flu. I'll be talking, Mohammed, you can get the first slide on here. Like the 1918 Spanish flu, COVID is now...
Yes, doctor, it's loading.
Fantastic, fantastic. You can keep me in as a small picture-in-picture. Just to let everybody know that we have so far lost nearly 4.5 lakh, that is 450,000, 430,000 people due to this disease over the last few months. In several countries, like in our own India, it is still on the upstroke, and the worry is whether 500 to 800,000 lives will be lost. The big worry is thousands, at least 20,000 healthcare workers, 200,000 have been afflicted by it, and anything between a few thousand, we don't know the exact numbers, 3,000, 4,000 to 5,000 have died because of this. A large number of healthcare workers in Spain, Italy, the UK, the US, and now in the UAE and in India have lost their lives because of this disease. Therefore, as healthcare workers, we have to protect ourselves. So we brought together this little presentation called Laparoscopy in the Time of Corona. It was one of the Nobel Prize winning novelists. It's called Gabriel Garcia Marquez, and his book is called Love in the Time of Cholera. So we just made a little joke on that and made it laparoscopy in the time of Corona. So let's go to basics. Everybody knows, you can see in your screens, this coronavirus, like this ball with multiple spikes. Please note that as doctors, what we have to know is that these spikes are the ones that cause the damage. The crown-like spikes. Only 6 coronaviruses have been known to man, but 2 in the past 20 years have caused pandemics. The SARS-CoV-1 and the SARS-CoV-2. And what's going on now, the COVID-19, because it came about in December 2019, is called the SARS-CoV-2. Now, having said this, we must understand, looking at this picture, as a doctor, as a surgeon, I would first want to know how this virus could enter my system, how from a patient it could come to me. And for that, what is very, very important for all of us to understand is the size of the virus, 1, and 2, whether it can float about, footloose and fancy free. Next slide, please. We now know that this virus cannot float about completely free. It needs to be suspended in a droplet, which is called droplet infection. The WHO was worried whether it could actually be suspended in air, in which case it would be very, very much more harmful to human beings. So you're a gynecologist, you're a surgeon, you're a healthcare worker, a nurse, you're in theater, you need to be careful and protect yourself from suspended particles of the coronavirus. The virus by itself, as we will study, is 0.06 microns, very tiny, but fortunately for us, it is suspended in moisture. And therefore, if you can do a good filtration, of course we use HEPA filter, which filters of all particles 0.02 or larger, you can be 100% sure. But you can see this Mona Lisa walking around with a mask as Corona Lisa. Despite the pandemic, hospitals are beginning to take in elective cases. You and I are going to be dealing with more and more patients. How can we protect ourselves? A proper protocol is required for the safety both of the patients and the healthcare workers. There's a joke going around that so many husbands and wives are spending time together during this period that 9 months or 10 months from now, there are going to be born a bunch of babies like the millennials. The name of the babies born between 81 and 95. There's like the millennials is going to be the coronials. All right, so let's study the aspects to be considered. My topic was laparoscopy, which I've been doing for the last 30 years in the era of COVID. All right, so the patients with or without the disease, we need to consider that. So first thing, every patient, and this is compulsory in the UAE, United States, many countries, every patient undergoing any elective or semi-elective procedure should have had a COVID-19 test, and the result and the swab should have been taken about 3 to 4 days, within 3 to 4 days of the surgery. This is a fair gap considering that one could be infected by a coronavirus just on the day before the surgery or on the day of the surgery. But arbitrarily, a 3-day gap has been created. Number 2, the doctors also before a surgery should, within 72 hours to 96 hours of a surgery, should have tested negative for the COVID swab with the PCR. So, to protect the health personnel, both in terms of getting the virus and in terms of getting sued by a patient saying, you gave me the COVID virus, it's very important for us to take control of the situation. You can see this, a patient saying, I think I caught COVID-19. And the doctor says, no, don't worry, it's not COVID-19. It's just lung cancer. It's almost as if people are more scared of COVID-19 than lung cancer. So both patients and the staff should feel comfortable entering the OT. You can see this picture. You need not keep the patient as comfortable as this picture seems to suggest. Educate the medical and the non-medical staff about handling bodily fluids and disposables. Very, very important. We need to minimize the number of staff in the OR. If you have an option between laparoscopy and open, it's probably wiser to choose open than laparoscopy. For example, slim young patient with an appendicitis, which you could do laparoscopically or open, in this era, it would probably be wiser to go open. You have to use personal protective equipment, and every staff member should be protected always. Look at the last point, deep cleaning of the OR after each case. Please remember that the coronavirus is killed very effectively by quaternary ammonium compounds, by soap, by Dettol. Everything, commonest things can easily kill the coronavirus. That's why it's important to do a deep cleaning of the OR after each case. Now I must stop here for a minute and say ORs are essentially not negative pressure areas. They are positive pressure areas. So when you're considering intubating and extubating a patient, that is when the patient has the highest risk. It is therefore recommended that the intubation and the extubation be done outside the theater in a so-called negative pressure area or an infection isolation zone, and then the patient is shifted into the theater. How do you create an infection isolation zone? It's very simple. You can just keep a HEPA filter very close to the patient, within 1 meter of the patient, and then you can intubate the patient. After intubation, the HEPA filter is switched off and taken in when the patient is taken into the theater. During the operation, the filter is switched off, and at the end of the operation, the patient is brought out and extubated with the HEPA filter in place. You all know about the PPE recommendations. The current recommendation is every healthcare worker in contact with every patient should wear a PPE. There should be a minimum number of healthcare workers inside the operating theater. It is not enough just to wear PPE. One has to be careful about how one takes off the PPE. You all know that the standard recommendation is, as you peel off each layer of personal protective equipment, you have to use the sanitizer to kill any possible bacteria that would have been in between the layers of the personal protective equipment. Now, I'm going to move on to something which is very important to every one of us who is using diathermy in the operating theater. HIV, human papillomavirus, and the hepatitis B virus have all been identified in surgical smoke. The infectious potential of these viral particles is at this point of time unclear, but in a COVID pandemic, there is still cause for alarm. We don't know whether you can get the virus along with some aerosol that could be inhaled. Every one of us in the good old days of open surgery without smoke, with diathermy, without smoke evacuation, there used to be so much of smoke. I don't know how many thousands of surgeons have inhaled thousands of smoke particles. This is a very important study called the Annam study, the Annam Hospital study from Korea, where they looked at the amount of hepatitis B virus in the surgical smoke that was emitted during the performance of laparoscopic hysterectomies and laparoscopic cholecystectomies. And they found that out of the patients who had hepatitis B virus, out of the 11 positive patients, their surgical smoke carried in 10 patients, in 10 of the 11 cases, their surgical smoke carried the hepatitis B virus, which brings us to, do we really know what we are inhaling? Is it only because of corona? No. Even after the corona period, we need to be careful about the inhalation of these smoky substances. And that brings me to the next step, namely, how do we get rid of surgical smoke in our theaters? After the coronavirus era, we can't go back to theaters and say, never mind, we'll smoke in whatever happens. The goal is to provide guidance on surgical smoke safety precautions to help the intraoperative team have a safe environment. Very, very important. And for these, the 4 magic points are given in the bottom right end of your screens. Number 1, personal protective equipment. Number 2, smoke evacuation. Number 3, a smoke filter or a particulate filter. And number 4, suction. Every gynecologist, surgeon, anesthetist, and healthcare worker going into theater should be aware of these magic 4 words. If you ask me to stop the presentation now, I would say remember these 4: PPE, smoke evacuation, filtration, and suction. I have already spoken about PPE. I'm now going to speak a little bit on the smoke evacuation. When you do laparoscopic surgery, if the cut or the porthole incision is a little larger than the trocar and cannula, there will be what we call a peritrocar or pericannular leak. And this leak will carry with it not just smoke particles, it will also carry with it viral particles like hepatitis B, hepatitis C, and coronavirus. Enough studies have shown that there is a diffuse spread of coronavirus in all the cavities. So when you insufflate carbon dioxide into patients, patient insufflation. When you remove the specimen, you remove it with a flourish and the entire abdomen decompresses and that smoke comes into your face or your assistant's face and you laugh it off. Not anymore, ladies and gentlemen, not anymore. So when you deflate the patient, when you insufflate, and when you remove the specimen, one needs to be very, very conscious about this. So what are the IFSO? This is the International Federation of Society of Obesity Surgeons who do obesity surgery, and the American College of Surgeons guidelines that surgical team and anesthetists must wear PPE, including a facial visor, which, as you know, is definitely superior to a regular FFP mask, an N95 mask, and gloves. A minute here to say, what's an N95, what's a KN95, what's FFP2, what is FFP3? When you're in theater, as far as possible, the most highly recommended mask is the N95. The N95 is the green mask, which is made up of multiple layers with a pulp inside, which does a filtration of 95 to 98% of the particles. The KN95 is a non-pulp based mask made in China, not following the N95 rules of the US, nearly as good as the N95 in terms of filtration, but not as good as the N95 in terms of fitting. It doesn't fit as perfectly as an N95. So if you're wearing a KN95, you need to do what's called a fit test and figure out what works for you. And finally, what's important if you're doing a 1 hour or 2 hours surgery, sweating inside there with your visor, etc., you need to be able to breathe well. In terms of breathability, the N95 is far superior to a KN95. So filtering viral particles is one thing, but protecting ourselves is also a very important thing. Feeling comfortable and being able to breathe is also an important thing. So there is definitely a higher risk of aerosol exposure during the time of endotracheal intubation at the start of the surgery, during endoscopy, colonoscopy, laparoscopy, any form of insufflation, you have to be careful. So let's look at the guidelines by the American gastrointestinal endosurgeons, their guidelines. Number one, use as small a port as possible so that your trocar and cannula fit snugly into that, so there's no air leak, pericannular air leak. Carbon dioxide insufflation to be kept down to 10 or 12 millimeters. Smoke evacuation and ultrafiltration to be done. That's the next part I'm going to talk to you. Finally, pneumoperitoneum to be evacuated via a filtration system before you remove the specimen.
Sorry, Prof. Sorry to interrupt you. Slides are not moving. We're still in slide 1, actually.
Oh my gosh, I made a mistake. I'm so sorry.
It's okay.
Yeah, you know what? I'll take control of the slides.
That will be good.
Can you see it now? Is it better?
Yes, now changed. Yes, thank you.
Oh, I'm so sorry. This is about precautions. I'll see if there's anything I left behind. This is the slide that's showing that there was a detected hepatitis B virus in surgical smoke. And this is something I want you to carry home. HIV, HPV, and hepatitis B have been identified in surgical smoke. I'm sorry about that. Now, this is Chuck Norris. In India, we've got a Rajnikant. He's been exposed to the coronavirus. Now, the virus is in quarantine for the next 2 weeks. So precautions for known COVID patients. You have to maintain a low intra-abdominal pressure. We teach patients teach doctors to maintain pressures of 15 or 16 millimeters sometimes during complex pelvic surgeries, cancer surgeries, and bariatric surgeries. But for patients with COVID, keep down your pressure to 12 millimeters or less. Use disposable trocars. You don't know whose trocar is carrying the virus. Small incision and evacuators or filters. Somebody said if you had to give a name to the Chinese coronavirus, you have to call it the Kung Flu. So this is not really important. So till today, there's no real treatment. We're treating patients every day. I'm in charge of a large COVID center, and we're giving them HCQ and antivirals, but we know that it doesn't really work. Now, in second half, let's look at it. A recent study showed that all recent studies are false. I also want to add about webinars. Somebody sent me a message that said he's going to conduct a webinar on how you can avoid going to webinars because there have been so many of them. Right. So how will you tackle the aerosol? Remember, if you tackle aerosol, you tackle coronavirus. I've got only 13 slides more. We are on the 17th slide. So the most important 3 or 4 lines that I talked to you about are coming in now. You have to keep instruments clean of blood and other body fluids. There is something called blood pooling in theatre, in surgery. Even a few drops of blood, if they pool into an area, it's called a blood pool. You need to suck and clean it out because that is where the coronavirus can stay. Any fluid is a chance for the virus to sit. Liberal suction of smoke and vapors during surgery, and there's a fantastic instrument that I like to use called the MARVAC, which is made by J.S. Martin, which actually activates the suction the minute you hit the diathermy button. So when you start burning, you start sucking. It's both interlinked by using a local intelligence circuit. Finally, avoid using the so-called two-way pneumoperitorium insufflators because what will happen is if the one patient is corona positive, it may contaminate the circuit and the second patient might then get it too. So how can we protect the operating room staff? Very important. Insufflators, good insufflators, smoke evacuators, filters, and PPE. These are the most important things. Now, surgical techniques. As a surgeon, we all like to bang, burn through tissue, but you need to keep the electrocautery settings should be as low as possible. I know some young surgeons, some of my students are also listening. Please remember that this electrocautery, whether it's robotic, whether it's laparoscope, remember that the tool that is holding the tool is more important than the tool that is being held by the fool. In other words, it's the surgeon and not the instrument. So keep your electrocautery settings as low as possible. Avoid long dissecting time and excessive use of energy sources. If you keep burning something, like you want to set it on fire, you will have what's called smoke plumes. And the smoke plumes may contain hepatitis B and HIV and now coronaviruses. You also have to make sure that there is no sharp injury or damage to the protective equipment of the team. Now, this is a very intelligent instrument. Smoke evacuators. Many companies have been going on and on saying, please use our smoke evacuators. And we were all casual about it. But now the time has come to take this seriously, to filter the surgical smoke. Now, all these smoke evacuators, I like one called the MARVAC. There's a specially designed filter system. Now, this corresponds to the ULPA standard. It provides safe and effective protection in the operating theatre. Now, there are many smoke evacuator devices where you have a filter. The advantage is that the filter will prevent particulate matter, which is beyond 0.06 or 0.02. Anything beyond that will be filtered by it's like a HEPA filter. It's part of the smoke evacuation process. But how do you know that the filter is working? Well, to solve that problem, MARVAC, the J.S. Martin guys, have come up with a filter that will tell you that when it needs to be changed, almost like in the high-tech cars. There is an inner surface which is larger and a smaller outer surface. And the large inner filter surface provides a long-lasting life. This device actually indicates to you when a filter needs to be changed. The great worry for a surgeon is using something and not knowing whether it's doing its job and whether you will be subject to a virus attack. That's me with the MARVAC. MARVAC, I'm looking very happy there, you can see. And if I see if I can expand that, that's the instrument in my hand. You can see that when I press the diathermy button, it actually activates this corrugated PVC piping, which is attached to the MARVAC. And you can see that this is the place where the filter is attached. So the whole thing is automatic. This is the ready-made settings for standard laparoscopic surgery, and I need not worry that any smoke is going to remain inside. It gives you virtually a smokeless kind of environment, and that's my personal promise to myself to keep it smoke-free for everyone. Let's go on to what's an air seal. See, an air seal, it's a newer type of trocar that ensures that there is, in the air seal mode, a residual leak during time of excess pressure. The way to do this is, the advantage of doing this is that you will be able to obtain what's called a closed system. When you intubate somebody and connect them up to a ventilator, then the endotracheal tube, the ventilator, the circuit and back, that's one closed system. Similarly, if the trocar is in the smoke clearance mode, there's a closed loop flow in which you can insufflate into one trocar and take out through another trocar, and this helps to clear the smoke and the contaminants. I'm sure many of you, whilst operating, have seen the field filled with snowflakes. These snowflakes are actually smoke flakes. And ideally, you have a good suction smoke evacuator, which deflates the patient after surgery, so that after you use the air seal, no COVID-19 containing particles could escape into the operating room. There are some pros and some cons for the air seal type of trocar cannula. It's a low pressure insufflation, closed system with filters, easy to use. The cons is a large capital purchase, not easily transportable to other rooms, and relies on filters to clean the recirculated air. So I've given you two different types that you can use in the COVID-19 era, air seal or the Marvac. Now, if you have a Kalis-Martin kind of a diathermy, the Marvac and the diathermy come together, or if you have another one, any type of diathermy, it fits in with that. In terms of cost, you have to look at cost in a world that has just lost, several $1 trillion in the last few months. I would personally push for something that evacuates the smoke with a filter. Now, what is a HEPA filter? A HEPA filter is probably one of the best types of mechanical filtration in the operating theatre. You know that if an operating theatre has a HEPA filter, it needs almost nothing else. It gets past the highest levels of accreditation. The size of the filter is 0.02 microns, whereas the size of the virus is at least 3 times as large as the filter. So if you're using a HEPA filter, in the filtrate that comes through the HEPA filter will contain 0 viral particles. Now, if you're bagging somebody for a longish operation to the endotracheal circuit, if you can add where the oxygen tubing comes in, after the oxygen tubing, you can see in this picture, after the oxygen tubing and before the mask, in this gap, if you can put the viral filter between the EtCO2 and the oxygen tubing on one side and the mask on one side, this is really the ultimate way of preventing viruses from the patient from reaching the bag or the oxygen or the EtCO2 circuit. And you can see this is the entire circuit carrying the smoke evacuation system and the air seal along with it. If you have a smoke evacuator and an air seal and a HEPA filter here like this combination, smoke evacuate plus Marvac air seal plus air seal plus a HEPA filter, then almost all particles that are 0.02 or larger are very efficiently filtered by the system. Since the coronavirus is 0.06, you are completely in the clear if you use a combination like this. So again, let's look at filters. The main disadvantage in a filter is that there will be some air leak into the operating room. There is lower smoke clearance capability if you're using a filter. It's not adjustable, and there could be some passive leak if there's no protection against pneumopressure loss. The pros are compared to the others, having a HEPA filter by the side of the patient is inexpensive, it is easy to install, and ever since the COVID era has come on to us, more and more HEPA filters, which are easy to install and disposable, are coming around. To the married men out there, be nice to your wife, because restaurants are all closed and they're all dependent upon our wives. So these are the pros and cons. I want everybody who's listening to me to understand smoke evacuation, careful use of diathermy, air seal, avoiding leak from the trocars and cannulae, utilizing filters, good PPE, using the air isolation infection room. These are the magical ways of preventing COVID. In a few minutes, I will finish up with the presentation. And I would like to say that more than 200,000 now have died all over the world and still counting. Mostly they've died in Europe, and in China, nobody knows the numbers. Please look at it. The confirmed cases are 7.5 million and still counting. The deaths, 423,349 and still counting. So I want everyone to stay careful and to stay safe and to use science to help us, not voodoo, to use proper scientific techniques when we do our surgeries, both to protect patients and to protect ourselves. You can see the puma saying that the only effective lockdown is the size of the puma is looking like a bull after the. I also would like to say that patients who are obese and who are bald and obese is nearly all middle-aged men in India, but bald and obese combination is very bad for COVID-19, higher risk. So with these few steps, to summarize once more, everybody should wear PPE. Keep as few staff as possible. All intubation to be done in an air isolation infection room. Keep a HEPA filter, a kind of the air filter that is disposable close to the patient at the time of intubation and extubation. Deactivate the filter during surgery. Evacuate all the smoke during surgery. Try to use lower levels of diathermy without charring and smoking. Try to use a built-in system that removes the smoke as you operate. And if you have a choice, if other things are equal, opt for a quick open surgery rather than laparoscopy. As a laparoscopic surgeon, when I say that, you must understand that that's the truth. And all of you, stay safe. Thank you all for listening to me. I'm happy to take a couple of questions if there are any. And I would like to thank the Sharjah Surgical Institute, Professor Nabil Sulaiman, Dr. Taiba, and Anil and Mohammed for having put this together. I hope this can be kept aside for surgeons and laparoscopists and gynecologists to continue to see and learn. Thank you, and I'm absolutely happy to take any calls. I promised everybody I would finish at 5:45. There we are.
Thank you. Thank you very much indeed, Professor Raja. I think it was a lovely overview. Thank you very much for your time and for volunteering your time to give us this lovely overview of laparoscopic surgery and corona, I should say. And I thank all of the people who have attended. That's great to see a good number of people attended. And as Prof. Rajkumar mentioned, the floor is now yours. If you have any question, I prefer you open your mic, ask the question, and then mute the mic. باسل دكتور باسل تفضل. دكتور راج this is the okay. دكتور باسل تفضل. دكتور باسل عندك question? Do you have a question, Dr. Basil? If you don't have a question, then please use Dr. Basil. Mute your mic if you don't have a question. I thought you have a question. Anybody who have a question? Hello? Anybody who has a question? Muhammad Ashraf, Muhammad, do we have any question in the chat? Muhammad?
If nobody has any questions, it means it is all very, very clear or very, very unclear. One of the two.
To me, it was clear, and I'm not a surgeon, so so it must be.
I would like to ask a question, if it's okay.
Yes,
Dr.
it's
Zainab?
okay.
Yeah. I wanted to know, do we need to install all these filtration devices, suction devices, only during the time when we experience that we have a COVID positive patient in laparoscopy, or because till now we didn't receive any patient who did any surgery in our hospital positive with COVID, or do we need to start preparing from now to install all the devices and not to wait till any patient arrives with the COVID positive?
It's a brilliant question. Ma'am, my answer to you is the same that I tell people. You know, they say, I do a HIV test, and for a patient, he's HIV negative. So I won't get anything from him. But that's wrong. He could actually be having the antigen in him, and the antibody for HIV will show up after 3 months. And during that period, when he has antigenemia, he is most infected. And that is why in the US, every patient you have to have universal precautions for every patient. Similarly, you have a patient who has had a COVID negative test on an RT-PCR swab 4 days ago, 3 days ago. 2 days after that, that is 2 days before your surgery, somebody coughs into her face. The virus is going around. She hasn't yet had the RT-PCR. It's not possible for us to do RT-PCRs every day, and then you're operating upon her. How do you know you won't get the disease from her? I can tell you something. In fact, going forward, good smoke evacuations, filtration devices will very soon become a must. Already they're a must for most JCI accredited hospitals, etc. They will become a must in all theaters, almost like the universal precautions that you take for all patients. So the answer to your question is, we should start installing these, and they're not frightfully expensive. They are much less expensive than a lawsuit if somebody lands up with COVID or HIV.
Okay. Right.
Good question, ma'am.
Thank you very much. Thank you.
Hello, sir. Dr. Ashish here.
Yes, Dr.
Can I have
Ashish.
a question? Yes, sir. For using the energy sources, is there any difference between the smoke generated from the bipolar, monopolar, as well as the harmonic scalpel? Or is it the same, or how is the risk? Actually, is it more with when we use harmonic scalpel, or is it less when compared to the bipolar or monopolar?
Very good question, Dr. Ashish. So far, there's not been a proper study comparing whether the particulate matter is more or less. But we know that all three generate smoke. The smoke generation is maximum in monopolar, a little less in bipolar, a little less with a harmonic or with a ligature or the newer vessel sealing systems. Why is that? That is because the amount of amperage that goes into the tissues is much more in a monopolar and a little less in a bipolar and almost nil in a harmonic, which uses ultrasound energy to heat up the functioning jaws of the scalpel. But what's most frightening is whichever you use, especially with the monopolar, the smoke plumes have live viruses. I showed you the Annam study from South Korea. And that to me is very frightening. That means all these years we've all been inhaling these viruses and these smoke particles. A number of studies are showing higher lung disease in surgeons and higher lung disease in anesthetists because unconsciously we are taking these in. We're not smoking, but it's almost like passive smoking. So I think all of us should be looking at using these routinely in all our theaters. Good question, Dr. Ashish.
Thank you. Thanks a lot, sir.
Right, if there are no further questions, I would like to tell on behalf of SSI and Professor Sulaiman that we are looking forward to a large number of courses, both MRCS and FRCS courses, as well as laparoscopic hernia courses, bariatrics courses, lap gynae courses, and lap oncology courses. And we are looking forward to a long and fruitful relationship with SSI. I would like all of you to pass on the word to more people that a number of good courses are going to be on very soon. Thank you. I must thank every one of you for having been a fantastic audience.
That will be great, Professor Kumar. It will be our delight and a pleasure to work with you. And actually, also in the pipeline, that there will be professional diploma in laparoscopic surgery soon. It will be advertised after we finish the discussion with Prof. Kumar and others. And this is in the pipeline soon. It will happen, inshallah. And Prof. Kumar have added this a lovely addition, and that is live experience in his hospitals, and that will be great. So if you are interested in this professional diploma, or you know somebody who is interested, we will appreciate it if you could pass the word. And we'll hope to see you in SSI soon, inshallah, after this lovely thing, visitor COVID
Yes.
goes away and finish.
Fantastic.
Okay, thank you.
Great.
Can we have a few minutes with you, Prof, after everybody else has left it? Okay,
Absolutely.
guys, thank you again very much indeed
Thank you all very much.
for attending. It's a great. Thanks very much. Those who are interested in certificate, communicate with Muhammad Ashraf, who is and I should thank very much the organizer, Muhammad Ashraf, Anil Kumar, Luan, and all the staff of the SSI. Have a great day. Thank you. Anil.